NICOM. It's a medical school in Long Island, and I did research at Mount Sinai a few summers ago. I still get their emails today, so I saw that the alumni topic was going to be anesthesiology, which is a career field I'm very much interested in. So I emailed the coordinator. He said it's okay to join the call, and very much looking forward to it. So thank you.
All right, perfect.
Thank you for jumping
Tony,
on. Welcome.
Yeah, Tony, I see you next. Oh, sorry, Jonathan. Let me cut you off.
Oh, and I was just going to say I'm taking a gap year in between third and fourth year, just to give context.
Great. Tony, you made it.
Yes. Hi, my name is Tony. I'm a first-year medical student at Sinai, and I'm really interested in doing anesthesiology. I've shadowed a bit, and I feel like it's definitely top 1 or top 2. So I just came to learn more about kind of what you did and I guess your whole story.
Okay, and I see, is it Mamie?
It's Essie. Can you guys hear me?
Oh, yes, we can.
Can hear you just fine. Yeah, great.
My name is Mame Essie. I am a current prep scholar here at Sinai, currently doing oncology research. I am in the midst of applying to med school while studying for my MCAT right now, and I've always been interested in anesthesia. So I saw this and found it was the perfect opportunity to hear more about it.
Great.
Love it. Thank you for joining.
Barbara, I see you next.
Hi, I'm Barbara. I'm a first-year student. I'm also interested in anesthesiology. Particularly, I'm curious about obstetrical and anesthesiology, so that's why I signed up to hear more about that.
Okay, and then we have Arun. Arun, are you able to introduce yourself?
Hi, I'm Arun. I'm a second-year master's student. I'm applying to MD PhD programs this year, and I was just kind of, I guess, curious about the subject and kind of hoping to kind of diversify my interests as I'm applying.
Awesome. Love it.
Great. We have a great range of students. So I guess, Dr. Berman, I'll let you start with your life story from wherever you want to start from birth on.
Oh, man. Starting with small topics, aren't we? Okay, so starting at the very beginning, I was born at Mount Sinai. I was born in OR 62. If you guys have been on the L&D floor, it's the big OR. After 36 hours of labor, I was a C-section. My parents never let me forget that part. I was born and raised in the New York City area. I went to NYU for undergrad, and then I was at Mount Sinai for medical school and residency. And then I decamped and self-exiled and ended up in Baltimore for my fellowship in obstetric anesthesia. So these days I do about a third of my time is high-risk OB and fetal anesthesia. And so I do a lot of anesthesia for fetal surgeries. So for instance, kiddos with spina bifida or kiddos with airway malformations and stuff, we do in utero surgery. So we do that. We're probably among the busiest centers in the world for that. And then I do about a third of my time is hepatobiliary, so Whipple, transplant, that sort of thing. And then about a third of my time is trauma. And we have a fair share of trauma in Baltimore. And that's sort of what I do. I help run our residency program. And I love medical education, love talking with learners at all stages in their career. And I'm so glad to be doing this.
Sorry, Kiva, I think I missed you. Can you just tell us quickly what year you are in school? Or not? Okay. Oh.
Yeah. I'm a first-year medical student here at Sinai.
Okay, great.
While you're born at
Sinai,
Aaron Hall for some of them. I see some Aaron Hall in the background. I was 14N for a while.
Oh, I think I was 14M actually.
Neighbors.
I know. I remember actually because that's like a multiple room, right? Your suite. I remember there was a bunch of guys in there that didn't pay their Con Ed bill for many months, and believe it or not, they will shut the power off if you don't pay. So they actually had the power shut off in their room.
My roommate in med school was not very conscientious about lots of things, including paying the power bill. So I had the bill switched into my name so that we didn't get our power shut off. So, yeah.
So I guess, the obvious question, why anesthesia, or how did you decide on anesthesia and when?
Yeah, so people ask a lot about this stuff, and I really don't think that there's one like defining moment. It wasn't like there was a golden laryngoscope that appeared in the sky or something like that. That's just really not, at least how I found my field. I know there definitely are people who wake up one day and say, "Oh my God, this is the coolest thing in the world," or at least that's the narrative that they tell. But I'm not sure that that's really how most normal human beings choose specialties. And so I found that I liked a few things. I liked medicine, internal medicine, but I didn't like the speed of internal medicine. I liked surgery, but I didn't love the idea of everything that came into being a surgeon, from a life perspective, from an outside perspective. And I really liked the OR, but I liked the intellectual aspects of the OR as much as I liked the manual aspects of the OR. And so for me, I was sort of choosing between anesthesia and ENT, because ENT is both a medical and surgical field in the sense that you do a lot of in the office and office-based stuff, but also do a lot of intense OR stuff. And I ended up choosing between anesthesia and ENT, and I realized that if you wanted to do academic ENT and do really crazy cutting edge stuff, it would mean a lot in terms of time away from family. Just being totally honest, and knowing that the two options were either that or sort of a more private practice style, doing tonsils and thyroids all day, but not necessarily having the full intellectual stimulation of being on the cutting edge. Whereas in the anesthesia world, that's much more something that you can do. And so at the time, I did not have kids, but I was thinking about what my life would look like in 10 or 20 or 30 years. And it's really tough to balance the medical career and family. And so I thought that that would be probably among the easier things to do in anesthesia. I ended up also having some really good mentors at Sinai. So some people who are still in residency program leadership, Adam Levine was one of my career mentors early on, and he's still been a very good friend. I talked to him literally yesterday. He's now become a close colleague. And there were a number of other people who were really helpful and influential in my decision. And now I have a wife who, despite everything, continues to stay with me and love me. And now we have 2 small kids. And so I found that the aspects of anesthesia that I love are the flexibility. The fact that I can be home with my kids for dinner on a relatively predictable schedule, but that I can also do really cool shit in the OR.
Yeah, your day-to-day sounds pretty fascinating. But I guess before we get that, what is a typical week for you?
So I think a lot of it depends on what your job looks like. So for me, I do a lot of time involved in resident education. So when I'm not clinical in the OR or the ICU or labor and delivery or whatever, I'm teaching lectures, or I'm working on physio simulations with our medical students, or I'm in the anatomy lab doing cadaver dissections of neuroanatomy for our regional anesthesia people, or doing simulation training for codes or ACLS, that sort of thing. So when I'm clinical, I end up either in the operating room as an anesthesiologist, so doing sedation and or general anesthesia and or nerve blocks for procedures. When I'm on labor and delivery, it's a combination of C-sections and epidurals and sometimes fetal surgeries. And I will occasionally also cover the ICU. So today I was covering one of our ICUs where I work as an intensivist. Not initially something that I wanted to do, but something I got sort of thrown into at the beginning of COVID, and ended up finding that it's a great educational experience for our trainees, and it keeps skills fresh that I otherwise wouldn't use.
And as a medical student, did you rotate on it? Because I think you rotate, is it like a week or something, right? It's not a long rotation.
And I'm not sure how it's scheduled now, because I graduated from medical school and I still had hair, but from what I remember, the surgery clerkship, I think, was 10 weeks, and it included 2 weeks of anesthesia. And so a lot of people in my med school class ended up going into anesthesia. We had like 20 or 22 or something people go into anesthesia, but it was mostly because we had early exposure. At some other school, like at Hopkins, the anesthesia clerkship is actually not a required clerkship. And so I firmly believe that very few people, unless they themselves had a parent or a relative who was an anesthesiologist, or they themselves had a very transformative experience with an anesthesiologist, no one comes into med school and says, I would like to render people unconscious to the point of near death, but reversibly, right? That's just not something that a normal human being does. But it's much in the way that no one comes into med school and says, I really want to be a pathologist. Yeah. And maybe some people do, right? Very possible that people watch Dexter and decided, I really want to be a forensic pathologist or whatever, but it's not common. And so there are some fields in medicine that everybody knows what they do. Everybody thinks they know what they do, like cardiac surgery, neurosurgery, orthopedic surgery, urology, or OBGYN or whatever. People have an idea of what that looks like. I don't think people come into med school with a firm idea of what anesthesiologists do. And so I had those early exposures. I certainly enjoyed my time in our physiology course as MS1s, where we went into the simulator lab and we gave different vasoactive drugs and saw what happened in the simulator to learn your alpha receptors versus your beta receptors versus your dopamine receptors and your vasopressor receptors and whatever. And then I loved my third year rotation.
At the first years, did you guys do that this year already or not yet?
And I'm not sure. I know that some of the curriculum has changed since I graduated. But we all had to go into the sim lab twice as MS1s. And that really turned a lot of people on to anesthesia.
And then as a first or second year, would you recommend that they try to shadow this early or try to do research? Or do you think, third year is fine? Or
I think it's a really tough question to answer. I think everybody's so focused on how do I get a match into a good anesthesia residency? How do I get into a good program? How do I make myself look good, et cetera? I think if it's not something you have the bandwidth for, you shouldn't force yourself to do it, right? Shadowing is for you more than it is for the person who you're shadowing. And so if you feel like you're overwhelmed in your life on a day-to-day basis, and you don't have the time to spend shadowing someone for a day because you feel overwhelmed or underwater, don't do it. If you're not passionate about research, don't start a brand new project that's going to be a ton of work if it's going to take you away from the things you love. But if you feel like it would be helpful for you from a decision-making perspective to go and explore the field, spend a day in different areas of anesthesia, see a liver transplant for a day, see a cardiac case for a day, go to OB or see a PEDS case or something like that. For your perspective, I think it's great. But from the perspective of trying to strengthen your application, that's really hit or miss. There's so many opportunities for you to strengthen your application, whatever that means, that I'm not sure you need to set yourself up for success in that way as a first year. There are some fields where that certainly helps, right? If you're applying into plastics or you're applying into derm, that longitudinal research connection and those longitudinal connections can help for sure. I don't think our field is one of those fields, mostly because we realize that people don't come into med school wanting to be an anesthesiologist. So if you haven't shadowed or gotten involved in research in your first year of med school, that's totally okay, because I don't expect it from our first year med students.
Arun, you look like you may have a question brewing there.
And I should apologize, by the way. My wife says that I give long answers to short questions. So apologies
That was
for
perfect.
that. Or rather not apologies for that.
So if you have questions, I'll let Arun ask. And then if you guys have questions, please feel free to just take yourself off mute.
I actually didn't. I was just listening, but I will be sure to insert one when I have it.
Great.
SC.
I have a question. So I guess I'm a bit different from the other students here as I'm not in medical school yet, but I am going to be applying soon. I've always had a gut towards anesthesia, but I'm really trying to gain exposure to it. So I guess in my position now, how would you say, or what would be advice to gain that exposure into the anesthetic world?
So if you want to gain exposure for you to make, to ignite your passion, etc., just send a whole lot of emails. That's really the only way that you're going to get to. And that's certainly the only way that I did it as a medical student when I wanted to shadow. I shadowed Dr. Marin, who is I think it probably is still the chair of surgery, and he's a well-known vascular surgeon. I love Dr. Marin. And then I ended up shadowing Dr. Port, who's one of the breast surgeons. I shadowed I think Dr. Gladstone. I shadowed a whole bunch of surgical subspecialties, and really the best way to do it is just to send email.
Repeatedly, by the way, I would say repeatedly.
Because we have, and I now know from the perspective of the attending who gets all these emails, we get hundreds of emails a day from people who are pulling us in all directions. And if we don't respond, it's not that I don't like you, right? It's not that I am thoroughly uninterested in education. That couldn't be further from the truth. It's just that there are so many things pulling us in all these different directions. And so it's not a badger. It's not it's not as if like someone sends me an email and I think, oh, they sent me an email. I'm definitely not ranking them in our residency. That's not how it works. So send the email, wait a week, send the email again, wait a week, send an email to another person. Just keep on pestering people nicely and kindly.
So going back to the specialty you're doing, the high risk OB, that sounds fascinating to me in terms of doing the surgery intra. Can you talk about how you kind of got to that path then?
Yeah, so I think a lot of it is serendipitous. I initially, if you had given me a multiple choice test when I was a first year resident and said, where are you going to end up? And all 5 choices were an obstetric anesthesiologist in Baltimore, I would have told you the test was wrong. I would have told you there was something wrong with the question, because I never ever would have predicted that this is where I would have ended up. But realistically, when I was choosing the specialty at the end of my residency, and I'd done an extra couple of months of cardiac anesthesia, so I did a lot of extra training for big heart cases, and I liked them. But towards the end of my residency, I was sort of agonizing over what I wanted to do with my life. And I knew that I liked education, and I knew that I liked the academic stuff, but there wasn't anything really pulling me in any direction. And then one day my wife said to me, you're never angry when you come home from OB call. She's like, you're angry sometimes when you come home from trauma call. You'll never guess what this person put up their butt last night, right? But I'm never angry when I come home from OB call. Sometimes I'm tired. Sometimes I have emotionally challenging or provocative situations. Sometimes there are bad outcomes for sure, right? That comes with the territory. But and my wife knows me better than myself. And she said that I'm never angry when I come home from OB call. And I said, you know what? I think you're probably right. Let me think more about that. And so I ended up doing an extra rotation in OB anesthesia, and I took a couple of extra calls. And I said, this is pretty cool, because when things go wrong, they go really wrong really fast. But then you could potentially save lots of lives. Like a mom with triplets, that's saving a cumulative 300 or 400 years of life. If you potentially save this person's life and the kids have good outcomes. And so I sort of thought more about that. And then when I was looking around for specialties, for fellowships and all that, I thought, wow, the in utero interventions, super cool. So we do a lot of fetal spina bifida, a lot of fetal, like it's called fetoscopic. So like a scope that's dropped inside the uterus to intervene on fetal conditions. We do fetal blood transfusions. We do fetal airway procedures for diaphragmatic hernias. We occasionally do fetal cardiac stuff. It's crazy. Do fetal urologic stuff, put in bladder shunts. It's nuts. It's straight out of science fiction. But I wanted to be at a place that did that sort of thing. and there aren't many. So when I was interviewing around, I ended up looking around and saying, Hopkins seems like a really cool place.
Sounds amazing. I'm like, I'll just deal with the knees and shoulders.
And I mean, it's really, and I think if I wanted to do more of the high volume, low risk stuff, there are plenty of places that can do that. And our labor floor is sort of the opposite. We're relatively low volume. We do about a third of the volume of Mount Sinai, but about 80% of our patients are high risk.
Wow.
So these are patients who probably never should have gotten pregnant for one reason or another. They have, like, one of our patients today had a stroke 4 months ago while pregnant, and then had a stroke a year and a half ago prior to pregnancy. Was told you probably should never get pregnant, and ended up getting pregnant. We've had patients who have liver transplants or heart transplants or both, and then decide to get pregnant even though they probably shouldn't. Patients with mechanical heart valves, which is really complicated managing anticoagulation, who probably shouldn't get pregnant, who do. And so it's our job to keep them safe and to give them the best shot for a good outcome.
Yeah, definitely one of the things I love about being in the OR is having the team there, the nurses, the scrub techs, the anesthesia. And I'm sure for you guys, it's such a close-knit team just because of the procedures you're doing. And they need to have the same team over and over again.
Totally. And that's why we end up, especially for a lot of high risk cases, we end up having, there's only a handful of us from each specialty who do these cases. And that way we all maintain a cohesive culture. And that's not true for, if I'm doing a lap chole or whatever, a lot of my colleagues will do those cases, but for very specific stuff, we have smaller teams.
I'll pause for any questions from anyone?
I want to hear from you guys. Yeah.
Yeah, so just this maybe a silly question, but what's like the patient interaction like in anesthesiology and the follow-up? Like, where do you get your satisfaction from? Something along those lines.
So when I initially was looking at anesthesia as a field, that was the knock against it for me, was you don't talk to patients. And I think, in fact, the exact opposite is true. When Dr. Colvin sees a patient, and I can say because I've been a patient of Dr. Colvin's, when Dr. Colvin sees a patient, he has half an hour to meet with you in the office, to get to know you, to get to know your history, to talk about the plan. And then if she decides that you need surgery, bring you into the OR at a later date, has that longitudinal relationship with you. You trust her that she's going to bring you into the OR and bring you out of it, and then she'll see you post-op. I don't have that luxury. I have 5 minutes, maybe 10 minutes to take a patient who I meet in the pre-op area who doesn't know me. I'm just a random dude, right? And I have to have, in those 5 or 10 minutes, establish your trust that I'm going to paralyze you, put you on a vent, render you completely unconscious, and bring you back to your family in as good of a shape as I saw you. And you got to trust me that I'm going to do that. And I have 5 minutes to make that contact, make that connection. It's crazy, right? And so I think the interactions that I have with people, I see people on some of the best and worst and most challenging days in their life, right? They're getting a new organ, or they're getting their cancer removed, or they're having their kiddo. And I think it's fascinating to have to build that trust so quickly. Do I miss the longitudinal relationship that I have with patients? Yeah, maybe, though I end up getting a lot of repeat customers on OB. People who I did their epidural 2 years ago, they request me again. And I think that's awesome. And some of my colleagues choose to go into pain management, where they have an office and they have a panel of patients who they see and who they can connect with. And they derive a lot of joy and satisfaction from that. That was never my jam. I never wanted to have an office and a panel of patients and have people I follow for 30 years. It didn't give me the warm and fuzzies. Not to say there's anything wrong with it. It wasn't for me. But you totally can. And there are also people who go into critical care from anesthesia. And so they don't have connections with people for 5 minutes, but they'll be the ICU attending for a week. And so they'll have a chance over the course of a week to meet the patients and their families, to build rapport with them, and to really make a difference in the lives of their patients. So if you want a long-term 30-year connection with patients, the field is probably not for you. Though you do make connections with your surgical team or your nurses or your scrub techs. But if you want an interpersonal challenge of connecting with someone in 5 minutes and gaining their trust, the field's awesome for that.
I love that. That's such a great point. That is so true that you have such a short time to do it because everyone's trying to hustle to get into the OR.
And I'm reminded of that myself. My wife woke me up from sleep about 5 weeks ago with right upper quadrant pain and ended up having gallstones. And we brought her to the ER. She had a lap chole and she met her anesthesia team 5 minutes before. And I'd known these people for years because I work with them. And she met one of them at a holiday party pre-COVID, so 3 or 4 years ago. But she otherwise didn't know any of my colleagues. And she met them and she was like, I trust them. They seem great. And that was after 5 minutes of a pre-op thing. And I was like, yeah, they do. And that's what it's all about.
Barbara, Kiva, or Tony, any questions? Mr. Berman has covered everything to a T. I guess one other question is, did you consider ever going into private practice versus academics? You seem like, obviously education has been a passion of yours, so I can't imagine that you had thought about not doing that, but.
Yeah, so it's interesting in anesthesia, the iron curtain between private practice and academics is at best a semi-permeable membrane, but is really like a very, very porous, because there are private practices that staff academic institutions, and there are academic institutions that have a private practice model for no residents or very few residents and mostly CRNAs. So I thought about it. In the academic anesthesia world, you typically have a little more time for research and teaching and all that stuff. I thought about private practice, and I actually interviewed for private practice jobs while I was interviewing for fellowship. I didn't tell each other that I was cheating on them, but I wanted to know what the landscape was like, and I wanted to know what I was turning down. I wanted to be an educated consumer. And so for me, I found that I wanted to be at a place that was doing cutting edge stuff. I wanted to be, in the words of Hamilton, in the room where it happens. And so you can't really do that in a private practice environment, but there are very, very compelling reasons to think about private practice as well.
I wanted to ask on slightly different note, you mentioned in your intro that you'd kind of gotten pushed into doing some intensive care work. And I was curious how you saw the scope and the practice of that field having changed, and especially coming from such a different field, anesthesiology, how you kind of saw the intellectual dimension of that.
I think it's important to remember that a lot of intensive care medicine is what we do on a regular basis in the OR, just slower. Right, so putting patients on ventilators, maintaining vasoactive, so vasopressors, maintaining acid-base balances, maintaining other physiologic homeostasis, blood transfusions, etc. That's all the stuff we do on a regular basis. Electrolyte maintenance, all that stuff is stuff that we do on a regular basis. And so as anesthesia residents, we rotate through an ICU for at least 6 months of our residency. So it's actually not, I initially said to myself when I was a medical student or when I was a pre-med, like, oh, was it anesthesiologist? No, it's just a bunch of button twirling and knob pushing and whatever. But a lot of the skills end up transferring and overlapping. And so about 3/4 of our intensivists at Johns Hopkins are anesthesia trained rather than trained in medicine or surgery. And so I didn't do an ICU fellowship, but at the beginning of COVID, we were completely swamped, and we went from having 180 or so ICU beds to having more than double that. And so I got asked if I would join the team as an ICU attending, and I said sure. And a lot of the skills translate pretty easily. People talk a lot about how anesthesia is ICU but fast, or how ICU is anesthesia in slow motion. And I think to a large degree, that's true. There are certain things that I was less, we don't do a ton of intra-op dialysis. So remembering the specific settings for certain renal replacement therapies was something that I had to look up because I hadn't done it in a while. We don't have a ton of palliative care discussions in the OR, but we ended up having a lot of those in the ICU, especially when COVID was really bad. And so brushing up on those are skills that I learned as a med student. Sinai has an amazing palliative care curriculum. And so I felt like I had a really strong background in that, but I hadn't used it in a while. So flexing those muscles that were sort of out of shape took a little bit of work, but I was really glad to have done it. And looking back in 20 years when my kids ask, what did you do at the beginning of COVID? I'm really grateful that I had that experience. It was super shitty, but I'm really glad that I had that experience.
What would you, do you think this is an accurate point that as an anesthesiologist, you're a lot more mobile in terms of your skills?
Oh, yes. And I think that's something that people don't necessarily realize. We touch pretty much every area of the hospital, and even areas you don't necessarily think of, like psych. We do the ketamine infusions for patients who have treatment-resistant depression. We do electroconvulsive therapy. We put all of our patients unconscious under anesthesia for electroconvulsive therapy. We do all of our IR cases, sedation for MRI or pediatric MRI under general anesthesia. Certainly everything in the OR, but everything also in the ICU and a lot of pain clinics. I think we are a very mobile group. By number of physicians at Hopkins, I think we're the biggest or second biggest department in the hospital. So we sort of have fingers everywhere. People talk about our department as a little bit like a spider. We have legs everywhere.
And I would think even if you want to move locations and stuff, the advantages of the practice, yes, are the long-term relationships, but then you're tied geographically and kind of have to start all over again if you move. But for you, you could really go anywhere.
Totally. And I think especially my friends in private practice feel that, for me, I think leaving a residency program would be really hard. So leaving the people who I've been mentoring for years would be hard. But I think for my friends in private practice who don't have a patient base, one of my best friends from work, his wife got a job in Arizona, and he said, "Okay, great, I'll move to Arizona." There wasn't a whole big like, "Oh, I'm moving my practice," and whatever. He just said, "Phoenix sounds nice," and I miss him terribly. But it was, from a portability perspective, it was quite easy to arrange that move. All right, from the rest of you guys, I want to hear. People have been quiet. I don't like quiet people.
So I might actually hop off. Maybe people ask more questions when I leave. But thank you so much for joining us. You almost convinced me to go into anesthesia.
It's not too late. I'm just saying.
All right. Have a good evening.
Thank you. Great to see you.
Bye.
All right, friends.
I just had a question about so like what's the role of say CRNAs and kind of mid-levels in anesthesia? Is that kind of changing the field at all? I've heard about this, but I'm not sure.
You ask a very complicated and challenging question. And I wish that I had a single good answer for you. So CRNAs are here to stay. In a lot of states, CRNAs practice independently, meaning they don't need an MD anesthesiologist as a collaborator or as a medical director. It's complicated. It's really complicated. What I will also say is that you will always have a job. And I'm not gonna guarantee that in 20 years from now, you're like, "Oh, Berman said I should always have a job," but you will have a skill set that is versatile, that is varied, and that will always be in demand. We know that operative interventions are going up. People are getting older. People are getting sicker. It's complicated politically. I think CRNAs certainly have a place in medicine these days. Question of how to use them best is a really complicated question. I can tell you that if I were having surgery or my wife were having surgery, we would not want an independent CRNA. Anesthesia is the kind of field where 99% of the time things are very boring, but 1% of the time they're not. And that 1% of the time is often unpredictable. And seconds matter. And having broad training and having great experience matters. But you know that, and I know that. Policymakers and hospital management doesn't always know that, and CRNAs are often cheaper. So it's a challenge. But I can also say that that's not unique to anesthesia. You have chiropractors who've decided that they're starting to give pain injections. Podiatrists who are doing total ankle replacements. So the foot and ankle orthopedic surgeons are up in a tizzy. Certainly have NPs and PAs doing primary care, which is probably the field that needs the most intellectual background and the biggest intellectual heft. Because you have to know so much to be a primary care doc. So it's certainly not the only field with turf wars and turf battles. Certainly not the only field where non-physician providers or mid-level practitioners or whatever PR buzzword we're using these days continue to encroach in the field. But what I will say is that you'll always have a job. But I think that's a really good question if you choose to go into anesthesia and then you're interviewing around for residency programs. Ask how the residency programs use CRNAs. Do they take away from the learning of the residents, or are they used to relieve the residents so the residents can go to lecture or something like that? Because that's an important question. All right, let's ask more hard questions.
Hi, Dr. Berman. I
Dr.
graduated from Hopkins in an undergrad, so I recognize like the Zayed Tower behind you.
Yeah.
And I know that Hopkins like stress research, education, as well as like your clinical practice. And like I saw that you're very involved in medical education, and I was kind of wondering like how are you able to get more into that, because I also see myself doing that in the future.
So I think that the important thing to know is that you can always get more involved in other stuff later, but you really can't get clinically good later. So I tell residents this all the time. You can always go back and get more training and education. You can always go back and get a master's in clinical investigation, but you can't do a residency a second time because you half-assed it the first time because you were so focused on other stuff. So right now, I think your best bet is to get as good as you can pre-clinically and then clinically, and then seek out early educational opportunities. So being a TA for gross anatomy or being a small group leader, small group facilitator, that sort of thing was really helpful. And then when I was an intern, I loved teaching the third year medical students. So I came up with a couple of chalk talks and said, let's talk about the management of a COPD exacerbation, or gave them procedural stuff. Let's talk about how to put in an ultrasound guided IV, etc. And so I just got more passionate about that, starting with as a med student and then as an intern. And then as residency got on, when I was a CA1, so a PGY2, my first year of anesthesia residency, I was very focused on just me, right? Getting good at doing the basics. But then once I got further along in anesthesia residency, I took med students along with me and had them learn to intubate. And I practiced not just doing, but teaching. But first you have to get good before you can help other people get good. But I love that passion. That's awesome. All right, what else we got?
I'm going to squeeze in another question. Is there anything
Sure.
you this is like the classic question. Anything you wished you knew about anesthesiology before you started, or any kind of like regrets, not like, anything that we should know about before?
Life's funny. I think would I have made different choices knowing what I know now? Maybe I would have chosen a different residency program. Maybe I would have chosen something different about my training. Maybe I would have chosen whatever, but life's really funny. So I think knowing what I know now, would I have made slightly different choices? Maybe. But knowing what I knew in retrospect, I wouldn't have done anything different, if that makes sense. I think the agony of what do I do with my life would be much easier if I had that realization a year before I did, of I like academics, I like teaching, and I actually don't mind the labor floor. That might have been helpful to have that revelation earlier than it did, save myself the existential dread of trying to find whatever academic home I ended up finding. But life is funny that way. It all happened for a reason. I'm not sure whether I actually believe that there is a reason, but it's a path, right? You guys are going to find your path, whatever that ends up being. And anyone who tells you that they got into med school and then did their residency and then chose a fellowship or a career and had zero bumps in the road, anyone who tells you that is lying to you or lying to themselves or both. We've all failed at some point. We've all had missteps at some point. We've all changed courses at some point, and that's totally okay. So yeah, I mean, there were definitely times where I felt like maybe I was on the wrong path or course corrected or whatever. But it got me to where I am today. I sort of learned to love the things that I initially hated the most. Stephen Colbert and Anderson Cooper did a podcast episode recently that I was listening to about grief. And Stephen Colbert talked a lot about when you feel like you're in a cave, turning that cave into a tunnel. And instead of feeling like you're trapped, turning that cave into a tunnel, seeing the other side, going through it, rather than feeling like you're stuck somewhere. And I love that metaphor, as cheesy as that sounds. Look at me, I'm Anesthesia Oprah. All right, what else? Barbara, you've been quiet.
Yeah.
I
So
call on people. Sorry about that.
you mentioned like how you split your time. What does that look like in like a typical week?
I don't think there's a typical week. Just thinking. So here, I'll pull up my schedule for this week. So, and it depends where you are, right? So my friends who are at Mount Sinai, their job is very much you work 4 to 5 days a week in the OR, plus or minus you take in a call overnight and then you get the next day off. For me, I do a lot of teaching and a lot of other stuff. So to give you an idea for next week, I'm on call Sunday for 24 hours in-house covering the labor floor. So I'm off on Monday. Tuesday, I'm interviewing our residency applicants. So I'm spending the day with our residency applicants. Wednesday, I am teaching a bunch of lectures for the medical school. And then Thursday, I'm on 24 hours on the labor floor again. And so I have 2 in-house calls, but I actually like call because I get off at 7 a.m. and then I have the whole next day off. And so I get to drop my kids off at school and then I go for a swim and then I can pick my kids up at school in the afternoon. And in the middle of the day, I can do whatever academic work, or I have to fix drywall in my ceiling in my kitchen. And I can do that next week also. So that there is no typical week, but a lot of it depends on the job that you want. I have friends who are my co-residents who work in an endoscopy center in New York City. And they work from 7 to 3, Monday through Thursday. No nights, no weekends, no holidays. And they make significantly more than I do. I'm not bitter about that at all. But it very much depends on the job that you want. The good thing about anesthesia is that, you know, I don't have my own panel of patients. I don't have my own office that I have to run. I can choose how much I want to work, and my salary is reflected in that accordingly. It's sort of like emergency medicine in that way. Some of my friends who are EM docs want to work a lot, and so they'll work 25 shifts a month, make a ton of money. A lot of my friends work 8 shifts a month and are very happy and still make more than enough to pay off their loans and to fund their travel, pay for their kids' private school, and then just chill the rest of the time or do things that they're passionate about outside of medicine. I remember when I was a medical student, I was like, there's things that you can be passionate outside of medicine, but there are. Tony, you had a question before I interrupted you by calling on Barbara.
So my question was, I know you mentioned earlier that you were really considering cardiac anesthesiology before you decided to go OB. So is there like a reason why you decided against cardiac, or just you liked OB better?
But I think a lot of it depends on the practice of what you actually want to do on a regular basis. I love cardiac anesthesia, I really do, but it is very protocolized. And so you have great surgeons, usually, and you do the same thing every single time. You induce with similar drugs, you have the same setup every single time. You intubate, you put in a central line or two, you sometimes put in a PA catheter, you always have an A line, you always have blood products available, and then you go on bypass. And 2 or 3 or 4 hours later, you come off bypass. Sometimes it goes well, sometimes it doesn't go well, and then you go to the ICU. And probably 5% of the time you have to come back for cardiac tamponade or mediastinal bleeding. And so it was very much a cookie cutter, same thing every day. And the patients are different and the cardiac diseases are different. And I don't mean to say that it's literally the same thing every day, but the anesthetic plan is not particularly different depending on the case. And that didn't seem as intellectually stimulating to me as having one day on L&D doing a fetal surgery and then the next day doing a crazy case in the main OR, and then the third day covering one of the trauma rooms and getting a couple of Baltimore gunshots. And so I like that variety. I like that intellectual ADD more than I liked doing the same anesthetic plan every single day. That's not to say that cardiac anesthesia is bad. Some of my best friends are cardiac anesthesiologists, and I respect the field tremendously. But for me, and what I was looking for in my career, it didn't strike me as sort of scratching all the itches. All right. Anybody else got anything? I'm gonna be like my 4th grade teacher and say, I'll wait.
I actually had a second question as well.
Yeah, please, please.
My other question was, so like, how big is anesthesia kind of like a more innovative field? Like, is there like opportunity for you to like work with maybe companies or like or like developing medical devices? Could you talk a bit about that?
So totally, and you know, the good part about anesthesia is that you have a lot of time to do that if you want to from a non-clinical perspective, right? Whereas if you were a surgeon or an internal medicine doc who had a panel full of patients all day, every day, that would be much more challenging to get away from. So we have people who, one of my colleagues designed a new kind of ambu bag that will tell you how much pressure you're using to ventilate. So that you don't over distend the patient's lungs and potentially distend the stomach. He got it patented. It was bought by Medtronic. And so these are the kind of devices that, like, if you design a better airway management thing, hundreds of thousands of patients a year have elective surgery. And if you have a good enough product, you can totally get a lot of market share. That's one big area. And the other big area is software development. AI tools in anesthesia are one of the new hot things. So sort of figuring out who's going to do well and who's going to do poorly and what we should be doing to optimize patients, especially in the OR, is the big black box of how to get things better, right? So what should we be doing in the OR for each individual specific patient? And so I have colleagues who are working on machine learning and AI algorithms for intraoperative decision support. And I think that if it becomes a thing, will actually be very helpful. That said, for the last 25 years, it's supposed to be a thing, and it hasn't yet. But if it does, that would be cool. So yeah, you could totally make money and do a lot of that stuff with device design and development. My friends one of my friends is a neurosurgeon who designs stents for aneurysms. Each of those stents costs like $40,000. So he gets a decent chunk of change for every one of those stents that's used all around the world. That's not what you're going to do. You're not going to build a $40,000 airway equipment. That's just not a thing. No one would buy that. But make a new tool that people can use and also pad your bank account. Totally doable.
I'll ask one more question. This is also
Sure.
maybe like controversial. So maybe you can get into it. What's the relationship between surgeons and anesthesiologists? Do you feel like you're respected for the work you do? Can you elaborate on any kind of like what's the collaboration like? I mean, I'm sure it's good. Sounds like you're very like high speed and like you can do a lot of stuff, so they respect you. But maybe like the anesthesiologist that doesn't do as many complex cases, how do they get treated by surgeons?
That's a really good question, and I think very much
Thanks.
of it is cultural. And I think if you're at a place that the surgeon is the top dog and the surgeon is the king and everybody kowtows to them, then you may not necessarily be someone who gets a ton of respect and appreciation, right? And my program director, or the current program director in anesthesia at Hopkins, and I are both known to say that if you wanted applause, you should have joined this circus. Right? Our field is not one in which you get a ton of thanks and gratitude and appreciation for what you do. And I plenty of my friends who are surgeons get Christmas cards every year, 10 years later, from patients who they took care of. It doesn't really happen for me. I'm okay with that. Like, if it's that or getting to see my family at night, I would so much rather see my wife and kids. But that being said, you can work at places where you have good relationships with your surgeons. It doesn't always happen. What I will say is that people recognize excellence and people recognize people who care. And so if you're an anesthesiologist who's not great, of which there are some, or you're an anesthesiologist who doesn't care about how your patients do, you don't close the loop with your surgeons, you don't think about your anesthetic plans as they relate specifically to a patient rather than just this is what I always do, people will recognize that. So targeting excellence rather than mediocrity, rather than adequacy is really important. And you gain respect by showing that. I have a lot of issue with the fact that we call our exams competency-based exams, because my target is not competency. I don't care if you're competent. They should be called excellence exams, right? I don't want you to be competent. I want you to be the best. And people recognize that. Yeah, some surgeons are not kind. I've yelled at surgeons. A few weeks ago, a surgeon started screaming at one of my residents. And I took him outside the OR and I said, I don't know who hit you on the playground when you were 5, but this is not how we talk to each other. I'm going to give you the opportunity to talk differently to me, or I'm happy to involve your chair. And now he's very nice to me. But I will say that It happens sometimes, right? But if you want applause, you should join the circus. I don't get the applause for a lot of the stuff I do, but I'm really okay with that. And I'm not joining the circus. All right, friends. I think we've reached the ebb of questions. Dr. Colvin has my email address. Since this is going to be posted on YouTube, I'd rather not say it out loud, but you can feel free to find it. Dr. Colvin and the alumni group has my email address. I would be happy to answer any questions you guys would have.
Thanks so much for your time and for
Thank you.
doing this.
Thank
Appreciate
you.
it.
Thank you.
Thank you.
Good night, everybody. Thanks.
Good night. Thanks.
Bye.